Alright. Alright, so we are doing ESD for a esophageal cystic lesion, which previously we have done ultrasound, EUS, and it appears to be above the submucosa. So I think it's more mucosal. I feel it's a simple cyst. So what we'll do is it's along the posterior wall. Actually, it has almost two components to it. And I think this is the distal one, and then we come back, and this is the proximal one. It's almost like a subepithelial bulge, right? Which you do for a poem patient. This looks like that, right? All right, cool. So let's see. Let's start with the markings, and we try to get both of these together. Okay. So So we do it successfully. We call it endoscopic submucosal excavation of the cyst, called ESE. Okay, this case may take some time, brother. All right. Okay. So needle out. Yep. 1 second. Yeah. Out. Hold scope. Okay. Yeah. Go ahead. Go ahead. Tell me what are you saying. Yeah. Yeah.
That lesion, as it is, it looks like it is in the submucosa.
Yeah.
So I think it's preferable to try to get to the lower third of the submucosa by doing
Yeah.
kind of maybe like in poem, trying
Yeah.
to get just above
Uh,
the muscle.
yeah. Well, the plan will be to be close to the muscle. That would be the plan in this case.
Yeah, yeah.
Out. Okay. I agree. Out. Ooh. Yeah, it's a little bit of a bulbous lesion there. So, okay. I think I could go mid. Yeah, I got a little more lateral there as I'm trying to mark here, but this is better. Let me go about it from
You
here.
should
Out here.
get the marking closer to avoid the circumferential stenosis.
Yeah, no, it's a good point. That's a good point. It's a relevant point. So I'm going to be close. Out. Yeah, reasonable distance there. But also in the process, I don't want to burst this cyst,
Yeah,
so
yeah.
we can take it out in a proper manner.
To avoid letting the mucosa of
Yeah, I'm just gonna avoid the.
deep in it.
It's a very thin mucosa. Oh, this is out. So I'd err on the side of being a little more in my dissection than out. But yes, point well taken that you don't want to do too much as well, because then you're cutting like a big circumference out. Yeah, very close to the wall there. Yeah, out. Out. All right, good. Out. Yeah, I think that's a cyst. This is the spine here causing that bulb. Honestly, this could be a part of the cyst actually. You know what? So I need to
As
come
it's
here.
like bluish
Yeah,
color.
bluish color to it. So I need to come out here. Although it is near the spine there, very close. Which you see on the EUS as well. Ah, come on. Hold the scope. So the scope tends to slip there. Ah, come on, man. Ooh, okay. Anyway, let's walk around here and this portion and then close. Just clear this. Yeah. So it seems fine. Let's see. We work straight from here and connect the dots beginning here, go all the way down here, and then connect the dots here. That should do it for us. Let's see. I mean, if we find a good plane, that'll be nice to be able to do the dissection. Of course, the goal will be to have the cyst removed without any puncture. But let's see how that goes.
I mean, starting as a poem would be good. Like
Yeah, tunneling. Yeah, I think that's what I'm probably going to do. Maybe go straight forward to backward here. Hold it here. Out. Whoops. Whee. Yeah, the problem is it's on the spinous process, so it's not giving me a stable axis there. It's fine. Out. And what I'll do is, with the interest of planning a traction in this case, what I may want to do is to have a little more space on the proximal edge so that we can grab the mucosa and, yeah, here we go. Need some marking here. Out. Yeah. Yep. All right, not bad. Close. Yeah, I think we've managed to capture this, and then if we can make some incision around this. So do two things. I'd lift here, cut here, so that there's enough space for it to grab the clip. Let's start with the injection and incision here. So you get a good dissection in this plane is important. So honestly, there's a little more space that I would have wanted here, but that's fine. Should be okay.
for the costs of
You'll change it. We're going to injection first.
use saline or glycerol.
We use Gelfusion out.
Olive oil.
Yeah, Gelfusion out. Inject. Well, inject. Okay, stop back. Yeah. Out. Inject. Okay, that's nice. Stop back. Out. Inject. Inject. Okay. Stop back. Okay, good. Nice. Okay. All right. Okay. 1 second now. Yeah, I think that looks good there. I'll probably just connect the dots here only. I'll not do dissection outside over there. Oh, okay, out. Does I have enough room from the end of the cystic lesion, you know? Give me the knife after this. Stop back. Yeah. All right. Okay, open. Settings are right, like the red endocut eye. Yep. Okay. Okay. Out. Okay, good. Hold scope. Okay. Out. Hold scope. Out. Yeah, it's just. So you want to, obviously take care of the muscularis mucosa well. And in fact, you need to have a good dissection of the submucosa as well, because otherwise you will have a problem when you do dissection later. Whee. Okay, it's not giving me a lot of space because of you know the orientation just below. Okay, open. Okay, hold it. Chodo.
Beautiful image of the fibers of the muscularis
Yeah,
mucosa.
this is all muscularis mucosa fibers. Yep, nice. So, well, there's a expected little bit of vessel there. What I'm gonna do is pakdo. Yeah, I'm gonna do the section all around here. Out. Okay, lovely. Okay. So yeah, fine. Let's see. Hold it. Hold it. Hold it. Yep. Hold the scope. Out. Yeah, the movement gets limited there. Okay. Yeah, chunky vessels. So we should. Yeah, the goal is I want to look at the muscularis propria at the bottom. Do enough dissection that I'm looking at it, which is here. So that's fine. Out. So the point is that we have cut through the deep submucosa. Distal aspect there. Okay. Uh, should I take the? Yeah, get me a coag grasper. Let's take care of those vessels. Unlock. Hold it. Yep. Hold. Okay. Yeah. Open. Close. Open. Close. Open. Close. Okay, hold it. Yep. Open. Yeah, so I'd rather do it because I think I'll have to address it later. Close. Open. Take care of it at different locations here. Close. Open. Close. Yep. Okay, and maybe this one here as well. Open. Close. Open. Close. Alright, good. Wait, should I? Wait. Take care of this also. Open. Close. Open. Close. Pakdo. Open. Sorry. Yep. Still use coagulation here because there can be some life in those vessels, you know. Out. Out. Okay. Fine. So let's see.
More difficult to put the layers, like considering the type of the lesion that we are trying to remove.
Well, I mean, it is. Let's see. When we reach there, we'll get to know. Injection now. I did my distal dissection. Now I'm going to go proximally. I'm going to cut through this area here. Maybe do a lateral incision all around. Let's start with the proximal part first. It's posterior, maybe. We could consider changing the position because it's now, you know, sort of posterior here. Out. Inject. Yeah, it's going to be very important to have a good understanding in this area because you may just end up cutting the, you know, cyst very easily. Stop back. EC ऑन करना है, बंद हो गया. Call maintenance. Yeah, nice bulge, which is great. Out. Out. Inject. Stop back. One here also. Out. Inject. Perfect. Good. Keep injecting. Okay, stop. Back. Okay. Um, all right. Let's see. This is a little bit of a, yeah, extension down here. Out. Yep. Hold it better. Out. छोड़ो. Let me just connect the dots, I think. Yeah. What do you think? Yeah. Oh. Hold it. Out. Okay. Injection. So I'll do a 360-degree incision first, and then I'm going to start the dissection after. You're done distal, we'll do some lateral, both sides. Out. No, wait. Out. Out. Inject. Stop. Back. Out. Inject. Stop. Back. Out. Inject. Back. That should be okay. All right. Nice. Okay. Out. Looks like it's the. Okay. Hold. An IDN? I think so. Okay. All right. Cool. Done that bit. Out. Okay. Okay, cool. Let's do the lateral this side now. Injection. So marking is very important. Otherwise, easy to get lost, and next thing you know, you've cut the cyst.
Yeah, it's
Yeah,
really easy to get lost, but
yeah, it is.
it's
It
something to
is.
do.
So appropriate marking is a must while you're doing this.
So this is the reason why you choose at the beginning to mark
Out.
it. Yeah, open it.
Yeah, just good marking around. Inject and a good lift. Important. Okay. Stop back. Right. Okay. Let's. Okay. Out. Inject. Yeah, that's good. I like that. Stop back. Yeah. Let's connect this here. Okay. Out. Inject. Stop back. Uh, Mostly okay. Out. Inject. Stop back. Okay. Give me
And at
now.
the same time, you can inject so much because you are not narrowing
Mm-hmm.
the lumen. The
I mean, I must be. I just want to make sure the lateral dissection is done so that we are, good on all the sides, and then we start with the submucosal dissection after that. Oh, okay. निकल गया तेरा ये this one. Marking is off. Out. Yes. Yeah. So let's see now. Where are we here? Whew, too much luminal narrowing now. So let's see. छोड़ो. Part of the challenge is now I can't see the marking well, and it's so edematous.
if we go down, we should try to follow the cut.
Oh, that's true. I think you could do down to up, like distal to proximal. I can see it well. Quick, come on, man. Let's see. Let's see. Where are we? No. Yeah. Okay. Yep. Maybe better idea is to pull back. Okay. Out. Yeah. Out. Okay. Hold it. Yep. Out. Yeah. This is a much better view, right? I mean, I'm seeing the marking on the right. So just have to go. Chodo. Oh, wow. I'm almost there. Out. Chodo. Hold it. Yep. Huh. Okay. Am I getting lost now? Yeah, I think there's a marking around. I hope I've not gone into the cyst, which I think I'm okay. Yeah, I'm outside. Let's see here. The marking, yeah, there was this one erratic marking,
Yeah.
and then I come up. and it's, yeah, this is where we need to be. Yeah, okay. Okay, left is better. Let's go left. Out. Yeah, it's something. We did something there. Could have been deeper, would have been nicer. It's very superficial, but it's okay. There's not no space to play here. But I'm going to connect these dots first, then we'll do second layer dissection later. Yeah. So I wonder if I can. Yeah. Okay. Okay. Out. It's okay. I'm erring on the side of superficial dissection, just because you know that you can always go one layer again. But if you cause a bleed, then that's a problem. As I said, that there's a bleed now. Wonderful. Okay, back. Coagulator. You know what? It's okay. It's an arterial somewhere there. The lesion is also bulbous, no? So the problem is that it doesn't give you much room. Yeah, I think so. Yeah. Mm-hmm. Yeah, it's somewhere there. Maybe just cut the top layer, maybe better. Gives us better idea of what's going on now. Out. Very pulsatile, man. Yeah, man, it's very. I think it's there, right? It's at 1 o'clock. Okay, coag grasper. See, it's behind that somewhere. It's okay, I'm going to stay steady and coagulate that area. We'll see. Open. Okay. Movement is a big challenge. Close. Close. Open. Close. I think that did it. Yep. Okay. Regular knife now. Yeah. Need to make a cleaner cut. This is good here. I mean, at least some muscularis There's so much edema here with the lateral side that, never mind. I think I'm just going to do layer by layer here. Because that's what happens. You can go a little deep and then out. You may have a little bleeding issue.
Yeah, yeah. It's, the superficial, the more the RCT,
You better.
the risk will be higher, the risk will be.
No, I mean, vessels is the key, right? So being superficial gives you don't hit the submucosal vessels if you're pretty superficial
But
in your approach.
the source is enough, like when you have
So you want to be
space.
superficial to avoid bleeding,
No,
so that you don't
to
hit
be
the.
to be profound because you have only like the less vessels because you have only the emergence of the blood vessel. So once you
So
get
if you want to avoid bleeding, you want to do superficial
yeah
cut
yeah yeah
first,
this is what
and then slowly you
in
go
my
to the
field it works
submucosa.
yeah yeah they recommend start
So
to cut deeper or start to get a good like specimen for analysis and for depth and also for the bleeding risk.
that's further out when you're doing submucosal dissection.
Yeah yeah
Right now we are only doing an incision. So when you're doing
yeah.
incision, that's when you want to be superficial ideally to avoid hitting the submucosal vessels, out.
Yeah.
And a little bit of cutting coagulation current there. All right, lovely, nice. Okay, lovely. Okay, fine, fine, fine. Hmm. I just need to connect this area out. Yeah, I can't make much movement here. That's the problem. All right, let's see if I can go this way. That bulge gets. Ah, wow. There's no space to move out. Out. Back. Do some injection here first. Some oozing. We'll take care of that. Out. Inject. Oh yeah, nice. Missing that. Cool. Keep injecting. Stop. Back. Okay. Yeah, those are vessels below. One of them is bleeding. All right, out. 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 Okay, just do a little bit here. Out. Okay, that's released. That's out. 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 Yeah, it's muscularis mucosa layer.
The large vessel is
Yeah.
good.
Yep. So that's released. Almost out. Yep. Gotta release that. Yeah. So cool, right? I mean, that's distal edge is good here. And well, the muscularis mucosa is well incised. And come back. All right, a little bit of cleanup over here. Ah, okay. Ismay, give me injection through this now. Out. 1 second. Ah, come on, man. Inject here. Stop back. Yeah, not the best of injections. Okay, out. Yeah, this is a little difficult here to cut. So, trouble early on, but fine. Okay. Okay, out. So there's a tendency to hurry up and start dissecting in the submucosa. You want to burst to have a nice incision circumferentially to avoid any problems later on. Yeah. Looks pretty good there. This one to cut. Out. Actually, I may just keep it for traction purposes here. This will help with a little bit of traction on the lateral side. This is where there was bleeding earlier on. All right, now give me regular needle and injection. Out. Inject. Back. Out. Inject. Back. All right, good. Knife. बेटा जल्दी लाना knife. ECचं काय झालं? Scope hold. Out. Out. काय चालू आहे? Why is the knife out like this? Out. Injecting. Stop. Back. Out. Okay, coagrasper. Yeah. Traction ready? Yeah. Change the direction. Okay, good. Open. Yes. Close. Open. Close. Okay. So I'll do a little dissection and then we'll put the traction. Okay. Okay. Injection here. Okay. Good. 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 Keep going. Stop back. Out. Out. पकड़ो. Out. चलो. Out. Ah, okay. Thing is over the spine and it just rolls, man. Ah, right. There you go. छोड़ो. Ah, damn, man. There's just no stability on the scope here. Out. Out. You see, this is the cyst over here. Better obvious on the left. Yeah, that's the cyst now. Okay, I think this is a reasonable time to apply traction now. Yeah, okay. And yeah, this is the this is helping me actually now with the traction. I left it alone. That traction is actually allowing me to do a little more dissection. Probably, but now with an external traction, I wonder if I should leave it or what. I just keep going and dissect more. Yeah, no, I think I should get. Yep.
This one is like hindering the dissection.
Yeah, it's not actually. It's helping a little bit to give me a traction. What I could do is give me injection first. This is a cyst clearly. Give me injection. I'm going to inject below this, and there's really very little space between the cyst and the muscle wall there. You can see. So you have to be very cautious with injecting in the right space and do gentle dissection there. That actually is giving me natural traction out. So I'm thinking of just using it right now, inject. I left it alone for that reason. Back.
If you are able to progress, then
Yeah, yeah, yeah. I think I'm getting some support there. Out. Inject. Keep injecting. Stop. Back. We use this traction, go center and lateral, and then later we cut it, get external traction, and go the right side. This traction, I'll let it use it right now, which is the proximal part. Out. 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 Ooh, hold it. This position it tends to roll. ये आकर पकड़ नहीं रहा क्या तू? ठीक है, मैंने ले लिया. Out. Inject. Yeah, hopefully made some progress. Let's see. I just go. The circumferential part takes a little while, but out. But you see, I'm already getting a lot of traction with the help of the, that 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 layer I left in the proximal part is actually helping. Inject here. Stop. Out. The goal is to take the entire thing out without puncturing it. That's the goal. Let's hope for the best. Yeah. Yep. Wee. Wee, wee. Okay. Yeah, inject there. I forgot the measurements. Where am I? Hopefully not too far. Stop. Out. Inject. Back. Out. Inject. Stop. Inject. Back. Out. Ah. Mm-hmm. Back there. Okay. How far are we?
Maybe around 1 centimeter more.
36 centimeters. Quite grasper. Yeah. About 1 or 2 centimeters now. Let's see. Yeah, I left this alone for a purpose, that's the reason now you see. What I'll end up also doing is do this section from this side, leave this alone till the end, and then do the section, maybe if this gives me. We still have to do a little bit of lateral stuff. Okay, yeah. Okay, open. Close. Open. Kalka cyst, huh? Yesterday the one we did US, same cyst. Hmm? Okay, I would inject. Yeah, 1 or 2 centimeters and we'll get there. So, but stop. No, we are doing a complete dissection and exposing the muscle layer, so it's not stir. Stir would be if I remove something, take it out, close the tunnel. This is ESD. Why it sounds different out? Okay, are you ready? Come on. Okay, good. Yeah, it's fine. Inject. Stop. Inject. Stop. Inject. Stop. Ooh. The scope's rolling as it's over the spine. So that's why you see these sudden jerks of injection movements sometimes. Out. Out. Ah, come on. Hold it here. Okay. Back to injection. I feel like 36, so measurement almost there. Back. Stop. Inject. Stop. Inject. Keep injecting. Yes. Okay. Stop. All right. Let's do it. So, I mean, I'm almost doing it very close to the muscle layer because we want to get the whole cyst properly separated from the walls, right? I mean, it's the goal. Yes. Out. Ah. Okay. Quite grasp. Yeah, I'm getting a feeling I'm there. Only a feeling. Yeah, that's it. That's the one, right? That's it. So cool. Let's take care of this. The lateral part is yet to be done, so I think just gonna go about, leave that proximal part there, and keep going about the lateral part with that traction only. Open, close, open, close. Okay. Out. Yeah. Okay. All right. Let's see. Back here. Inject here. Okay. Very nice. Stop. Inject here. Stop. Back. Inject here. Okay. Very nice. Stop. Inject here. Stop. Out. The oral suction. And the liquid's coming out. All right, let's see. Out. Out. Inject. Stop. The only worry is that you don't overshoot, obviously, which can happen if you've not. But I think I've done a reasonable dissection on that end, so I think it should not be a problem, but I'll still nevertheless check again. Out. Out. Okay. Uh, give me out. Yeah, what's it? What's it? Back. Quite grasp. Yeah, 35, 36-ish. So it should be somewhere here. I'm going to cut that part and see. Looks pretty good. Well, we'll see. Another half a centimeter. Go through these vessels, and we'll cut there. And I think we'll see the end now. Okay, open. Close. Ooh, okay, open. Close. Open. Wait. Close. Open. Turn, please. Turn. Yes. Open. Yes. Close. Open. Close. Yep. Done. Yeah, I see. No. That's okay. We'll do. Out. Check if the interrogation is done. Talk to Shraddha. Interrogation is done, then we can take the patient after this one. Out. Yes, so after the ESD, we'll take the patient after. All right, good. Wow, okay. Damn, where are we now? Things. I'm debating where are we? Unless we've gone totally on the left lateral side, which is possible. 37. Let's dissect from here a little bit now, so that there's no problem. Okay. Maybe I cut on the right a little more, and my tunnel is a little more towards the left. That could happen. Let's see. I want an injection there. Stop. We are in the vicinity. I don't think we have crossed. Out. Out. Yeah, I think. Okay, let's see. I think the muscularis mucosa here is intact. Back injection. I want to cut this whole thing. Did you order? I tell you, but I don't know. I'm not convinced. I think I'm going to dissect a little bit. Acha, no. Give me regular. Mm, no. A little odd, though. I don't know. Let's see. I'm going to do a lateral dissection injection here. Inject. Out. Inject. Stop back. Out. Inject. Out. Inject. Stop back. No, but I think I'll come out and just cut here first.
If you are in the right place.
No, I think to cut the muscularis mucosa. Otherwise, I'm going to overshoot very easily. I'm there. You know, I'm here. Given. Yeah, this is it, right? I mean, this is where we injected now, and we got there. Hmm. Out. Yeah. Scope. Yep. Yep. Out. Out. Yep. Nice. Out. Oh yeah. Out. So making sure the lateral part is in line and cut to the point that I will not overshoot when I dissect from the proximal part. So laterally we should be good as we come, on the far lateral edge, so that go from above, that should not be a problem. Out, inject, stop. Out, yep. Out, inject. बढ़िया, stop, back. Out. No, I mean now I'm going to choose the lateral left side first and leave the right side alone. That's the plan. What's perplexing is I think I've reached here, but I'm able to see the end right there, right? So I have reached the end. You see there? That's the end. That's the mucosa. I'm gonna, dissect this portion here. That will release it out, as I was expecting. Yep. Okay. No, I'm okay. This is the one which is holding us back, this particular friend. That's why deeper dissection at the distal end is important to avoid a problem there. So let's see if I can. Yeah, okay. Yep, this is what's holding us, right? Out. Inject here. Stop. I think, let me see. Let me just quickly see where we are. Inject there. Stop back. Inject there. Stop back. Yep. Out. Yeah, I think, let's see. Yeah, I think we are now going deeper there in that plane. So I think this friend here, I think you need to change, take care of this one here. I have to see the distal edge now. Well, okay, I've come from below. You know what? I'm going to do the lateral one now, and then we'll get to this one. Yeah. Okay. Let's finish this off. Inject. I want to leave that alone because the lateral one I get some more traction. So then I can keep cutting both sides and then last and then proximal and done. Back. Back. Inject. Stop. Inject. Stop back. Out. Back. Give me an injection proper. So it'll be, yep. Have to go like this till here. Because I think it's separated here. Yeah, I just want to do this, about 2 centimeter area. I'm going to do now. So once it's separate from the lateral edges, then I have the right and the posterior, inferior one left. Okay. Out. Yeah, I think here out. I'm getting it from the left injection. I'm getting traction from the remainder of the areas which I have not got back. Stop. Injection back. Yeah. Out. Inject. Okay. Back. All right. Nice. Out. Out. Yep. Whee. Okay. What's that? Yeah, I mean now it'll be submucosa inside. When you go here through this portion, there'll be something on the lateral aspect which we'll take care of now. Yeah, I mean I'm okay with this now. But yeah, you're right. IT knife is a good one. Separating well. Out. Out. It's only a sliver remaining. Out. Japanese don't use the IT knife much for this, I've seen. For esophagus. For stomach, they do. Oh, yeah, there you go. So, I'm separating it now. Okay. All right. Yeah, lovely. Lovely. Oh, okay. A little bit out. Yes. Okay, nice. So we got that part taken care of, right? Little maybe here. See, I mean, without any external traction, we are able to do this. Yeah. Out. Ooh, I have to be careful. I don't want to touch the cyst, which we have so carefully preserved till now. Out. Yeah. Okay, nice. Lateral, good, lateral, good, lateral, good, lateral, good. Out. Whew. Okay, I think it rolled off. All right, good. So lateral done. Let's see the inferior one that has to be done now. Out. I feel like this I've done before also. Where I think at some level I felt the inferior was done fine, nice, but somehow I don't think it's done well here. Yeah. Okay. Good. All right. Let's see. I'm going to leave that one alone now. Let's go to the lateral part here and take care of this. These two are holding it together. But, huh? Yeah, and that's an intentional approach that we are taking. There is out. Yeah, there's natural traction from leaving those portions alone. Okay, let's do this. Give me. Annoying. Back injection now. Almost done. Out. Inject. Okay. Stop. Back. Out. Inject. Stop back. Okay.
Has an option of a knife with a slightly broader tip.
Yeah.
Would you prefer using that over what IT or something to that?
I'm using a J knife right now. No TT, no IT here. Out.
Generally prefer
This
it has a
is.
broader tip
I don't know if it's gonna add much. You know.
with respect to the time of life.
No, I don't think so. We have a hybrid from Urbi, right? We don't end up T knife, hybrid T knife from Urbi, which has got exactly what you're saying, a broader tip with, with the ability to perform injections. But we don't end up using much because it's, I mean, I'm happy with the smaller tip. In fact, it's not necessarily that your broader tip will enhance your speed. You can it's, you know, you're always going to have vessels and stuff. So it's not like suddenly, you know, when we have an avascular portion, we are very fast, which you've seen before in tunneling and poem and stuff, right? So the avascular portion is not a problem. It's the vessels which is the issue. Out. Yep. Back. Okay. I need injection here. Okay, lovely. Keep going. Keep going. So I'm going more in outside in, just because I don't know laterally where we are, and you know, if I go from below, I feel like I may just go laterally, stop, um, and dissect more than I have to. So that's why here I've decided to go outside in a little bit first. So we have really nice dissection on the lateral aspect where I'm confident that I'm not going to, you know, make a mess of it. Pakdo. Yeah. So now you can see we've got a pretty good dissection there on these aspects. The whole submucosa is more nicely visible out. Patient is okay. Check. Yeah, so I've left this part here and now out. Okay, let's see, where are we? Yeah, not bad, not bad. I think this is the inferior part which I've left alone. Okay, good. Alright, let's see from below where things are. Okay, we still need to do work here.
Pick up this side.
And I'm outside. Yeah, I got the lateral part done. Out, inject here. Inject here. Stop. Inject here. Stop. Aha. Inject here. Stop. Yeah, I think that's it. This is it. Out. Out. Out, inject. Stop. Inject. Yeah, okay, out. Okay. Yeah, it would be nice to see the lateral part now. Let me go outside in or yeah, okay. Out. Inject. Yeah. Stop. Out. Inject here. Stop. Back. Yep. Out. Much better. Yep. Yeah. Out. Okay. Out. Looks fine here. Out. Inject. Keep injecting. You see, this is a cyst on the left, and yeah, I mean, there's little space there in the lateral part. Let's see. Inject here. That's good. Yep, yep, yep. Go, keep going, keep going. Good, good, good. Find a nice plane. Stop. Out. Out. Give me a needle and injection now. So enough. Yeah. What we'll do is go from here, lateral side, outside in. Now I have enough space, which was a problem going out first. Now there's enough space for us to do the injections and, out in dissection. Stop back. Out. Inject. Okay, thank God. Yeah, that wasn't working right. This is much better. Stop back. Out. Inject. Stop that. Oh no, did I hit the cyst? I hope not. Sounds like a vessel. Yep. Quick, quick, quick. Yeah. So, okay, open. Close. Open. Close. Oh, close. Open. Close. Alright, nice. Phew. Okay, let's see. No, let's dissect now this part now. Enough. I'm losing patience. I want to get this done now. It's like the last part, just the last part. That's it. You know. Yeah.
Any chance to cut the proximal aspect around the
No, not now. What I'm going to do is dissect it, connect it internally, and then distal, and then last I'll cut the proximal part. This is holding stuff together, right? I mean, otherwise out. Out. So actually, lateral is the more annoying and a tougher dissection sometimes. You can tunnel your way through, and then you're good. But the lateral ones can be very annoying because, yeah, the dissection gets more difficult. An IT knife does help in such situations. Back out. Yeah, I think it's connecting, right? You see that now? Yeah, there you go. That's what I was looking for. Forward two. So now you hook it up in that traction, portion there, and then go through the dissection. Then there'll be little strands which are out, holding things. And then what you do is find that V out, and then address it there. Yep, that's what's keeping us out. At this point, totally okay to use IT knife if you feel so. In fact, gastric, I was, pleasantly surprised. IT knife works really well. So they were doing dissection with IT knife through and through, which is interesting out. Because I've only used IT knife for such situations. Yep. Oh, nice. Oh, nice. Okay. Something left here, something left here. That's it. Out. Okay. Keeps going, man. I need to cut it somewhere here. Out.
does it help if you tunnel on one side rather than the other? So does it help if you do the lateral
Uh,
dissection? Or
no.
then it
I
will
mean,
anything?
there it is. Ta-da-ta-da. That's it. That's all we have left now. Out. Yeah, tunneling laterally cannot happen, right? I mean, this is. Okay. Better not hit the cyst. That's all. Out. Final stretch. Out. Feel like injecting to avoid this, but I think it's okay now if I'm at 6 o'clock out.
Yes, you would also allow retraction.
What's that?
Estimate the
Yeah, no, it's a great device. Yep, I agree. Okay, this just doesn't want to end. Okay.
the last
Yeah, it seemed like initially. Okay, come on. Ta-da, ta-da. I think so. I think so. No, no, no. More.
just push it.
Just a little more. Just a little more. Keeps coming. I think this is it. Optimistic. The push will do it. Yeah, I think so. I think so. No? Yeah? I think so. I think I'm seeing. Yeah, I think, yeah, that's it. Yeah. Okay. Give me a, something to guess. Hold it and pull it. That thing better not rupture. I'm taking it out. I'm like, I've saved the integrity of that cyst so far. Yeah, I mean, then defeats the purpose. No, I just want to make sure that we are all through and through. I thought we were done, but okay. Not that tooth. Yeah. Oh, alright, annoying. Go ahead, grasper. Open. Okay. Out. So the scope movement can be a little bit of a challenge in proclose. Yep. Proximal esophagus open. Close. This still is okay, but when it comes to proximal esophagus, sometimes we have problems with scope movement. You know what? I feel like there could be something attached here. You think so? Huh, Divagar? No, it's moving. Let's see. Yeah, I think if I get rat tooth, I should be okay. Quick. Okay, open. Open. Yes, close. Oh, yay! It is intact. I love it. Open. Okay, turn on the lights. Yeah. It is intact. That's
coming out of the esophagus.
yeah. I know. It's cool. All right, good. Let's take a picture on that. Yeah. उस पे just take a picture उसके ऊपर after this, right? Okay. Yeah. All right. So some coagulation and then we are done. Family को बुला दो एक minute. Yep. Huh? Ah, knife is okay. Knife is okay. No active bleeding, so it's okay. Little bit. 4 centimeters in length, about. You know, it's 50% of the circumference. It should be okay. Yeah, that's the hope, right? Yeah. Okay. Thank you. Good. I'll go to OPD and then we'll do the Burma case after. Oh, okay. Nice. Well, there's nothing really here that I have to change to blue light, yeah? No. Out. It's always a happy feeling to see it come out. There are too many vessels for me to coagulate now. Yes. हो गया अच्छे से दिखाओ उनको show the family the specimen. Oh yeah, that's it. Perfect. I wonder whether we should do injections or not. Steroid injections. I'm debating out. Okay, good. ठीक है. Okay. Out. Back. ठीक है हो गया पूरा का पूरा निकल गया जैसे देखा पूरा का पूरा स्पेसिमेन मिल गया अभी ठीक है Yeah, you know, I think we should do some injections here. I would say it is, yeah, it's about 60% of the circumference. So I would say, you know, you guys can help me. I'll go to the OPD. Just put some injections along the lateral wall in the submucosa. Have you done submucosal injections before? Okay, that's it. That's fine. It's steroid triamcinolone चाहिए रे. मिलेगा क्या order बुलाओ. Keep her like this until then. Yeah. Leave it alone. Okay, sorry. Yeah. चलो good. आधे घंटे में लेना उसको वर्मा को एक ट्राइमसिनोलोन इंजेक्शन लाना रे बाबा